So the driving force really for myself to go into orthopedics actually really started in high school. So high school, undergraduate, my training in Canada, and also did a little bit of a kind of postgraduate stuff too. And all it did was made me realize that I'm really hands-on. I'm very mechanical. I do a lot of physics and stuff, and I really understand that, and as well as math. And I thought, I want to be able to apply this biomechanically. And even before I made it to medical school, the first thing was I want to be an orthopedic surgeon. So trauma is pretty simple in that sense. You break something, if I can heal it without doing surgery, we will do that. Very simple. I give you the two options. You can do no surgery and treat it with a cast or a splint, or you can do surgery and get you moving back a little bit faster. And for every individual, it's different. It's tailored towards them. For foot and ankle, I'm very much against doing surgery right away, unless, of course, you've seen someone else and you've tried the whole gamut of non-operative management. I always try no surgery, and that would entail physical therapy, anti-inflammatories, splint, medications, avoidance of certain activities. My philosophy of care really stems around the patient understanding their diagnosis. I think work-life balance really started with my parents, because my parents are immigrants from outside of the country, and essentially their work ethic was work, 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 and then whatever you can is provide for your family. And that's kind of really instilled on me. My wife, really knew me before I went into trauma, and she understood what it entails and the lifestyle that entails. So she's very understanding, and she allows me to do all this. By her taking care of my family, it allows me the ability and the time to take care of patients. Orthopedics really can be from as simple as twisting your ankle. So you have a sprain, and that can be seen in my office. That can be seen almost by a primary care doctor, and then getting sent to physical therapy. It can get more severe to a fall and a break your ankle, break your wrist, and then get more severe to like a hip fracture in a geriatric patient. But it doesn't stop there. It can be motor vehicle accidents, fall from heights, and these are people that really need immediate help, and that's more in the hospital setting, such as multi-limb, multi-extremity injuries. Pelvic fractures are quite severe, fractures of long bones that can bleed quite a bit. These are people that are essentially, they're dying, or they're going to lose a limb, and they need the care, immediate care right away. And so for myself, my practice really revolves around both. My office, where primary care, urgent care, emergency doctors will refer to me, and those are essentially what we call walking wounded. And I can treat them on an outpatient basis, bring them to surgery if they need it, and then they can do this outpatient surgery that one day in the hospital and go home that same day. I feel like I'm the one that can do that for them, not only just surgically, but also talk them through it so that they're not as anxious before surgery, and then after surgery they're not as confused about how to get better.